Okay, we might get started. Welcome everyone. We have a wonderful session today. It's the first session after our town hall launch on Friday. Professor John Glover will be taking us through some wonderful work that they've been doing for a number of years. The title of today's work is Population Health Data Show Many Changes for the Better, but Are They Equitable? Before we begin, I'd like to do an acknowledgement of country. So in the spirit of reconciliation, Torrens University Australia acknowledge the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respect to their elders, past and present, and extend that respect to all Aboriginal and Torres Strait Islander peoples today. I also acknowledge that we're meeting on many lands and that I am living and working on a Awabakal country. I'd like to give a little brief introduction. Many of you know John, but some of you may not. John's the director of what we call FIDU, and that's the Public Health Information Development Unit, and it's located at Torrens University Australia. The unit has been funded by grants from the Australian Government Department of Health since 1999, which is a phenomenal effort. John and his team produce the Social Health Atlases of Australia with a focus on describing and monitoring inequality in health status, access and outcomes. His team is recognised for the quality of their work and understanding of the processes necessary to protect privacy and confidentiality of data. Using data spanning 40 years, from the late 1980s to the early 2020s, John, as director of FIDU, will share examples today of change in the health of the population and related social determinants across Australia. The data drawn from FIDU's website, and we can provide this in the chat, but it's at www.fidu.torrens.edu.au, and we'll highlight the extent to which improvements have been shared equitably. And there will be about a 40-minute presentation, and I think there's about, 10 to 15 minutes where John will field any questions, and then we will close. So over to you, John.
Thank you, Kerry, and appreciate that introduction. Thank you very much. Yes, I recognise that I'm hosting this meeting from the country of the Kaurna people, and also recognise the traditional owners of the countries where others are today and the First Nations people sharing this presentation. And I pay my respects to all elders, and past and present, and celebrate the diversity of Aboriginal Torres Strait Islander people and their culture and their connections to the land and waters of Australia. Let's share this screen. The presentation. So as Kerry said, that's the topic, and it's within this Research and Innovation Week for Torrens. The approaches that I'll go through are a series of slides to show inequalities, both socioeconomic and health related, with an emphasis on variation between communities and change over time. There will be time for questions, and the link to the presentation and the notes will be provided. And please use the chat to raise any issues. Claire's with me, and we can get back if there's anything raised that you wish to talk about immediately or hold for the questions. But very quickly, just a couple of slides about Australia in general. We know Australia has very good health status. You can see the life expectancy is above the world average. Avoidable mortality is below. We're above, but just a little bit low on average on ageing of the OECD countries. and self-rated health, being poor in health, is well below the average in the orange dots. The deaths from range of particulate matter, this is national figures, so international figures, so sometimes they're not quite so relevant. But the first three are definitely with smoking rates having dropped incredibly in Australia, although now we've got the challenge of vaping. Alcohol being a challenge, and overweight, obesity, certainly over the last decade's become a challenge. And air pollution, we're very low on that. And the last one I wanted to share, we just talk about a couple of the last two, the effective preventive care through mammography screening. We're not doing as well as that as we might. And also effective secondary care, the 30-day mortality follow-up after heart attack. We're quite low on those. There are other indicators in this series that you can go to that's on the link on this slide. But as we all know, it's not just the average we need to address. In any set of statistics, we know that it's not the same for everyone. There are wide variations in many measures of health status and health outcomes. And also there are wide variations in what we call the social determinants of health. And here's the definition from the World Health Organization. And I think it's pretty clear the conditions in which people are born, grow, work, live and age, all those forces and the systemic forces that are around us have an impact. Variations we'll look at are between populations and change over time. We'll look at them in maps, charts and data tables, with change showing over time through the charts and so on. And we're going to be looking at variations by inequality and then by remoteness. This isn't an eye test. It's just quickly to show you what appears on a website, and then we'll zoom in a bit closer. But this is how our inequality charts appear on our website, and where you can choose between Australia here, the capital city, or rest of the state. So you can look at Sydney or the rest of New South Wales, Brisbane, rest of Queensland. You can choose a topic. In this case, we've got early childhood development. And then within that, you can choose an indicator. And in this one, it's the children developmentally vulnerable on one or more domains. It may be children on track. It may be children developmentally vulnerable or on track for school readiness or for physical readiness. And the columns here show the data at a point in time. The columns go and show a range from highest to lowest socioeconomic status. So what we've done here is the 1,100 geographic areas we've got for Australia. We've grouped them into those where people live who are the most well off to the least well off, the most disadvantaged. And then we compile all our statistics under those headings. The measure of disadvantage is one from the Bureau of Statistics that comes out with every census, the index of relative socioeconomic disadvantage. So we can compile our data and we can see change between, or variation between the highest, these middle, and then the most disadvantaged, lowest socioeconomic status. The data is shown below here, and we also got notes and links to the actual data in workbooks. These charts available for every state and territory, as well as for all of Australia. Coming in more closely to perhaps see what's going on here. On the right-hand side here, we have an indicator called a rate ratio. This is showing the ratio of the rate, or the percentage in this case, of children developmentally vulnerable in these most disadvantaged areas to those in the least disadvantaged areas. With 86% higher in the first period, and in the second period it's 95% higher. A little bit of improvement here and very small here, but because of the improvement, it hasn't been much as the actual gap, the equity gap, as we call it, has blown out. Then we can look at other charts with the same approach. Again, the 5 sets of bars from highest to lowest in these inequality ratios over here. This is people who left school early. In the earlier bars, it actually school before age 15, but the people in their wisdom in education changed it to year 10, which is a little bit harder. People come from, say, Syria or Greece or South America or so on, and are now in their 60s or 70s, remember what year 10 is. But anyway, to know what it was in our terms, but at least we know that they're pretty comparable. And what we can see is there has been an overall improvement. All the bars in the later period, 2021, shorter. So that means that there has been an improvement everywhere. Unfortunately, again, this ratio of the most to the least disadvantage has gone from just below 2 to above 2. People in these areas have become more, have not improved as well. Their situation hasn't improved. And as, sorry, I should have said, obviously we include that indicator because having a secondary education and completing it particularly is really important both for people's future education, but for employment at a population level. Of course, we all know there are people who that doesn't apply to, but at a population level, it is really important to get that basis, primary and secondary education. The children in families where the mother has a low educational attainment, again, this isn't making a slur against mothers. It's because of the important role through the research that we know that mothers have in their families and for their children. And that is why the indicator is shown. And it's an indicator we can get every 5 years from the Australian Bureau of Statistics population census. And you can see this is a pretty amazing thing that since 2006, which are the lighter colour bars, 2021, the proportion of mothers has come down overall quite strongly. It's a reduction of 40% over those 10 years. So overall, 14% of children are living in families with mothers with low education achievement. Unfortunately, you know, the gap has widened. Something about the location where people live long term, and we'll come to that as well later, but it's gone from over 2.5 times in these more disadvantaged areas. We get from the universities each year the proportion of the number of children, young people who've gone from school, secondary school, into university in the following year. And you can see that that has increased over time. Although again, you know, these bars in this most disadvantaged are 43% below the most well-off areas. That's still, it's got a little worse. It's just 49% below because there's been a higher rate of improvement and of level of going to university from these areas. Again, you can see also that it's not just the ends of the spectrum. Once we move from these areas, the most disadvantaged, and it's 20% of the population across the whole of Australia. We can look at these, as I said before, separately for capital cities or rest of state or any state. It's as you move, each subsequent level is lower. And this is a typical pattern in so many, we call it the social gradient, and it appears in many, many sets of data. So a question that you probably don't need me to ask, but you know, why the emphasis on SES? And here shown as by educational indicators, we could use other indicators. Just wanted to point out that while many studies have commented on the contribution of socioeconomic quality to poor health outcomes, including premature mortality and hospitalisations, a couple I wanted to mention. In 1993, there were data produced from our first social health atlas of South Australia, which was produced in 1990. And they found that after adjusting for age, that socioeconomic disadvantage explained between 12 and 49% of the variation between postcodes in mortality rates, depending on gender and cause of death. And one of the biggest was for male mortality was 34%. And more recently, there's lots of other studies, but one in the UK that 1 in 3 premature deaths before age 75, attributable to socioeconomic inequality. And as they said, this is an important public health challenge and need to address upstream determinants of health. So we'll look at some of the health status and same 5 groupings as areas. This shows a strong social gradient in premature mortality, deaths of people before age 75. This is across the whole country. If you looked at this slide for any state, territory, capital city, you'd see a pretty similar picture. And we can see that the gap is 2.03, so it's twice the rate, an age standardised rate adjusting for age differences around Australia, but between this latest bar and the earliest, this last bar and the earliest. Another thing is we could use many examples of poor outcomes and greater burden, but in this chart, the rates of admission to hospital for potentially preventable conditions, admissions which could potentially be avoided with adequate, effective and timely primary health care. Very topical thing at the moment, primary health care in a federal scene. Examples are cellulitis or diabetes complications. And this is an indicator that the federal government uses and it's used in the health system. It's obviously much more costly to have hospitalisation than a quality primary health care system, not only in resources, but in terms of the burden on the person who's being admitted. The fact that primary health care system needs to be strong is something that drove the first South Australian Atlas and then the Australian Atlas is to be produced in the early 90s. So we've known this for a long time. Perhaps we're slow learners, but you can see therefore that the gap here of over 2.5 times, nearly 2.5 times between the most disadvantaged areas and the most well off in terms of this indicator. Again, no surprise, but the greatest differences between population groups are definitely those between Aboriginal and Torres Strait Islander people and non-Indigenous Australians. So here we're mixing a couple of things. We've got both Indigenous status and then we've got the socioeconomic status. So you can see the extent to which it varies for the Aboriginal and Torres Strait Islander people in the lighter colour bar, and the difference from there, actually the non-Indigenous and their variation too. And the variation is the huge difference in terms of the being able to participate in higher education when you're an Aboriginal person. That is improving and it has improved over time. It's one of the things that is doing somewhat better, but it's come from a very low base and it's very slow. It might get you to read the numbers here, but just to show you, again, the total potentially preventable hospitalisations, these conditions that I mentioned. Again, for Aboriginal people, the level is extremely high compared to the non-Indigenous. And if we go look at potential years of life lost, in other words, the extent to which people die early than 75, it's a measure that we can, it in fact awaits the data rather than just looking at the number of deaths. So if somebody dies at age 17, they obviously lose a lot more years of life lost than if they died at age 57. So this is a weighting and it shows you the huge loss relative to the non-Indigenous population of Aboriginal people from dying at an early age. We've also got this for other ages, 55 and 65. Again, and another indicator of that burden. Another way to look at the equity gap, inequality, is through remoteness. That bigger chart shows, the chart shows the data by an index that was created at the University of Adelaide a long time ago and is now used regularly by the Bureau of Statistics every census to look at a measure of remoteness. The way it's done is it looks at the variation people living in these 5 groups of areas from major cities, inner and outer regional, remote and very remote. It's based on a distance to service centres of different population sizes, and they use the population size as a proxy for access to health, education, facilities and resources. It's a rule of thumb. It's very rough. It's a bit like the unemployment index. It's not perfect. And the very remote, you could cut that up 10, 15 ways, as some people have done. But here you can see that most of the non-Indigenous population live in the major cities and through here, whereas the Aboriginal and Torres Strait Islander, it's a different pattern. And I've got over here just the numbers and the percentage of the Aboriginal population of the areas. So I just bear that in mind, that they are there, but given that their overall proportion is so small, it's got this thing in the way. I'll need to get rid of it. So I can't remember it's 3.4% overall, and 45% of the population in the very remote areas are Aboriginal, against 1.8 in the major cities. The remoteness chart shows a range of information. This is preschool enrolments. You can see the drop-off among Aboriginal children. It's by where people normally live. We can have a ratio down the bottom, and we've got the buttons to get to the data and all those sorts of things. Early school leaver participation in higher education, again, this huge drop-off. So for the non-Indigenous, of course. Unemployment is much higher for Aboriginal people in very remote areas. I mean, haven't updated this data to 2021 yet in this Indigenous Atlas. Sorry, knocked off the button. But this over here is the 2021 Aboriginal, and it shows it's the same pattern. Data include people who are Aboriginal who are involved in the community development program outside, particularly some of the outer regional, but certainly remote and very remote areas. Sometimes called the Aboriginal work for the dole. It's not really a living wage, and it doesn't give people the dignity of having a job. You often see that being said by Aboriginal people. There was a news item last week saying exactly the same from somebody in one of the remote Aboriginal communities doing that, but wanting a real job that meant something. So it obviously isn't an easy problem to solve. Relatively few job opportunities, some lower levels of education, not much skills training. The job opportunity is not there, but it is something that is so important if health is going to improve. Some of these things are underpinning health improvements. Low birth weight babies is traditionally widely accepted as a key indicator of infant health, and it's generally associated with poorer health outcomes, including increased risk of illness and death, longer hospitalisation after birth, and increased risk of developing significant disabilities. This is a statement I just read is available on the website. For every indicator we put up, we have a policy context statement, what we've got the data there for, referencing things like the Bureau of Statistics, the Australian Institute of Health and Welfare and other studies, and then the sources of data and how we've calculated and where we've got them from. But as you can see, low birth weight babies, the proportions are quite high, and they've actually been stuck there for about a decade or so. They had come down some overall, but they're not retreating as much as anyone would like. Very difficult conditions, of course, in remote areas, and just like with the potentially avoidable hospitalisations, to getting some of the diseases with poor quality housing and infrequent access to water, poor electricity supply, all of those things affect all of these outcomes. And women smoking during pregnancy and this is a pretty true statistic in that it's the women reporting to the midwife. So it's one of our most accurate statistics, especially for the very remote and remote areas where often the data can be less accurate, but it just shows you the entrenched nature of some of these things and the difficulty and the impact this has on the birth weight and so on. Premature mortality, again, the rates of Aboriginal people are just so much higher and increase with remoteness. And these preventable conditions, again, this is just showing the huge rate above the non-Indigenous rate for Aboriginal people. And of course, lack of facilities in the country, as I mentioned, adequate running water and good housing and access to medical care to get simple care that can fix cellulitis, say, and end up in hospital for some time with it. So the last set of, I lost my note here. A couple of things I wanted to say that related to the embedded nature of locational and social disadvantage over time. I mean, we saw the rate at which people left school early had improved over time. These data for Greater Adelaide in 86 on the left put into the 2021 boundaries show a markedly similar pattern 35 years later. Correlation coefficient is 0.88. So the rate is down by 56%. So the improvement is good, but it's not shared. You can see it's pretty well the same pattern. If you were a mind, and I haven't done it for the last election, but if you want to go back to the 3 previous state government elections that they won, the Labor Party won, and map the polling places, that the Labor Party vote by polling place, you'd be struggling to pick the difference from the map on the left or the one on the right. It's just something you might want to think about. Another thing is to look at Brisbane. The correlation here is not quite as strong, but the overall level had come down by 50% of who'd left school early, but the correlation is 0.6. And so it's still a very similar pattern for those areas over that very long period of time. Things haven't changed a lot. There was a bit of messing around with boundaries for Sydney, but I was able to see, we couldn't map it, but there was a 0.87 correlation in Sydney, which is a huge city, and there's still the same locational and socioeconomic pattern in Sydney over that long period of time. A couple more is these potentially preventable hospitalisations on the left. That's where they are occurring, where the people live. And on the right, people dying before age 75. Again, this strong similarity between those areas. In Sydney, this map of those two same things showing the burden borne by those people. So we have made improvements, but frequently haven't addressed the equity gap. This is the last set of data really, is just to show this drop in the premature mortality rate across the whole of Australia. The rate per 100,000 of deaths has dropped by 55%. That's a very good story. It's flattened out a little in recent years, but it has really come down hugely over this time. Fortunately, it hasn't been the same for everyone. As you can see, the bars for the 2020 in the darker colour, there's still a gap. And in fact, if we look at this table, a little bit busy, but if you look at this figure over on the right-hand side, this is the ratio of the people in this most disadvantaged to the least disadvantaged areas. And through to the mid-90s, it was around these 140, maybe up to 150, 1.5 times. Now it is double, because Improvement here is down 62% against 46% in these areas. People in the most disadvantaged areas now have a rate that the people in the least disadvantaged areas saw back in 96. It's a long gap. South Australia and Queensland were the slowest to catch up, and they've never caught up, have they? All they did was caught up to something years before. So, in summary, in Australia, we're obviously fortunate to have Medicare and the income support schemes we have, because they are so important to our health. But they're increasingly letting down the most disadvantaged through a lack of access to appropriate health service, adequate job seeker payments, and the most disadvantaged, and many others, through lack of provision of social housing and the level of the Commonwealth rent assistance. This next paragraph I wrote was something that was published last year about better and more focused primary healthcare being the way forward. But if the investment is only in emergency centres and GPs charging a fee for service, it will not make a difference to preventable illness and death, at least not for those with the poorest outcomes. Now, I talked about funding for community-controlled primary healthcare, which was a call back when I started mapping these data in the late 80s for South Australia. That's what we started about to do a long time ago. And I said such a big picture idea shouldn't be too great a challenge for our new federal government and dedicated departmental staff. Well, you're fortunate to hear that there were to be 61 primary healthcare GP super clinics. The program has these goals: more efficient primary healthcare system, lower rates of avoidable hospitalisation admissions, reduce health inequalities, improve health outcomes. This program, with its commendable goals, has the potential to be a step towards addressing the equity gap through a considered primary healthcare approach. But we know that to be effective, those with fewer resources also need access to secure housing, transport, quality early learning and schooling, secure jobs, and a welfare net above the poverty line. So in conclusion, I'd just like to acknowledge the support of many people and agencies, including the state, territory and others who provide the data which we present, to acknowledge the work of the team at FIDU, support of Torrens University, and the Department of Health and Aged Care's funding since 1999, which is, of course, the reason these data continue to be available. So thank you very much, and I'll hand back to Kerry.
Thanks, John. Yeah, I think I wrote down on my notebook sobering statistics, and then Belinda wrote something like, "This is heartbreaking." So some of those stats that you're showing, I mean, we're seeing improvements, but still a long way to go. Yeah. Are there any questions for John? I can't see anyone's hand up.
I'll need to go away and look at the thing later and think about it. It's a bit of a bombshell. Sorry, I was so quick. I should have slowed it down.
That's quite okay. Yeah. So, John, if anyone wanted to access and look at the atlases and dig a bit deeper into it, do they simply go to the website? Do they contact you? What will be the next step?
You're right on both accounts. They certainly go to the website at fidu.torrens.edu.au, and they're on one of these contact us, and they can certainly email to any of us at FIDU, and we'll get back, and there's some phone numbers there if people want to talk. And there may be something that's not there, that maybe something we can think of that's a proxy for data someone wants. And also people often come up with suggestions of something we might do better, or something that's not as clear as it might be. So yeah, certainly the website and contact, email or phone.
Yeah. Yep. I noticed, a lot of times, and I hope I'm not putting you on the spot, but, there's like a 2011, and then we jump to 2021 or 2006, and then we jump to, 15 odd years later. I know you had to pull out just a few things to show us, but Can people also look at what the trend might be between those years, and if there's something significant that happened in those years, that might show up in the data?
So one of the things I took out, because I was getting a bit, one of the slides a bit wordy, was that with the maps, it's difficult because until 2011, the boundaries changed hugely. It was ridiculous.
Yeah.
In 2011, the Bureau of Statistics did what they nearly did 10 years earlier, but didn't quite make it, and set the boundaries as a standard. And now we've got from 2011 on the same boundary. So we can look at maps, but the graphs, where we can, we go back as far as we can. Some of the data in the graphs will take us back for each state and territory by quintile or by remoteness back into the late 80s. Others, it's like the mothers with low educational achievement. We couldn't get the data before about 2006, but some data it's 2011. Often it's more frequent. We do have archive section on the website, but also we've still got the data that we published in 1992 nationally. And if people really want something from earlier, we can often get it. And then if the boundaries, we may be able to do something with it. So yeah, we're happy to take requests from people to look. And a lot of people do use the data over time, because as you say, often the time series might be at somewhere like the Bureau of Statistics or the Institute of Health and Welfare. We've got the small area data though, and that's where they might want to break it up further and get a time series. So yeah, it is possible. They just need to ask and we'll see what we can do.
Ask and you shall receive. And I think Rachel has her hand up. Thanks, Rachel.
Thank you. Thanks, John. Very interesting presentation. As usual, I think I'm very privileged here to have spent a long time working with John in my work history. In fact, my first job straight out of uni was working on a social health atlas, which was, I won't say how long it was ago, but it's decades, not years, let's just say.
Golden youth, that's right.
Yes, that's right. So, John, I just wondered about your perspective there on the GP super clinics, because some of us who've been circulating around SA Health can remember the old community health kind of infrastructure that got dismantled there at one point, or seemingly so. Do you think the super clinics are they like a halfway point? They seem to be very focused on avoidable admissions and that kind of thing, and they sound GP focused. I mean, are they? And are they a kind of approximation of anywhere near what the community health sector used to look like? Or do you think we've those days are over and we won't return to that kind of structure again?
I think it's very hard to get back, and I'd certainly agree that they seem to be GP focused. I mean, the bodies that are involved in the discussions and making these things happen are very powerful unions, if you want to call them that, and they will have a big role. Hopefully they'll have enough of a broad range of people, but we won't get back. At least in the mental health sector, there are community mental health services across the country, but the community health centres and services that do more than that are very much of the past, and which is really sad, because they had such a role to play in community development and health and supporting people. So yeah, I think that the clinics are possibly and potentially a good thing, but they don't replace some of the better things that we had, which is when we started this work with the health atlases. That was a real support and a strong focus of that we wanted them to be a major part, because the atlases were designed to give people in the community information that government had, theoretically, so that they too could advocate for their communities and for better services.
So I guess part B of my question would be, where else are we seeing the social determinants of health being taken up there then? Claire presented the other day on some policy work around child and youth health, where I think she mentioned that, we are seeing some uptake in some policy now, but it's obviously not universal, and it's not throughout all population groups or all places. Yeah, so I just wondered if you'd seen any uptake of social determinants elsewhere in the system.
We've never had a proper inquiry since the 80s, the late 80s, 88, I think it was, that really addressed what we should be doing, and then that drifted off over time. It's heartening to see, though, that there's a big inquiry in education, not only about preschool, but right through to university and proper funding, and trying to perhaps put the Gonski funding in where it's never happened, particularly for disadvantaged schools. And I think those sorts of things are useful and are part of the solution, because, you know, if we were paying proper benefits for job seeker and we had, you know, that real support for education, because as we know, the education support from the Commonwealth government is very much not to state schools. It's much more to private schools, and disadvantaged schools aren't getting the share they should. And I think there's hope that this, by the education minister, the federal one, might do something there. So that's one aspect where it might be taken up. But on the whole, I think the social determinants of health are talked about, but they don't really drive enough of the policy.
Rachel. Barbara.
Thank you, Kerry. Thank you, John. Those are extremely grim statistics. As a futurist, I wonder if you have ever considered looking for forward indicators that might add to the graphs, or, you know, might give people an idea of where things are changing in a more proactive sense. Is that something you've looked at or considered? Not so much forecasting, but there must be indicators, or the creation of indicators that could tell us where things are going before we get there.
Yeah, many years ago, there was some work that was looking at what would happen with continuing the scenario we were on, where we would end up with things like the proportion of the population on income support payments or early mortality. Still rather negative things, but and that was done a bit, and that did show that a trend that we probably have got to now, where it varies a bit. But no, I haven't really done that much, I'm afraid. But I understand what you're saying, and there probably are people who are better inclined and are able to do that than I can.
Sounds like an opportunity there.
Yes.
Angela, I think you've got your hand up. Yep.
I do. Hi, everyone. John, I just wanted to ask, I'm, I suppose, fairly early career. I've got a health promotion background, so we talked about social determinants all the time, and then sort of got into the health sector. I'm like, oh, am I the only one who knows what a social determinant of health is? Just listening to you talk, you've obviously worked in the space for a while. Do you think there's been a bit of a trend in social determinants being utilised more or being utilised less frequently just over time?
Well, I said, you know, that's often talked about but not acted upon in terms of policy. Certainly, the rhetoric in recent times, since we had a federal Labor government, again, it is appearing more and more in what you read in the general media and in releases. And, you know, the thing about the education, where the Minister of Education, Jason Clare, is looking at schools and so on. I mean, he comes from a background of coming from a school that was relatively disadvantaged, I think, and they do add their next step. One of the problems with the social determinants of health for many was that it was seen like health department trying to pass the problem off on other people in the early days, and it took a long time for that to pass, and that's taken decades, I think. But I think you're right, though, that there are, well, to raise it, because I think more people are mentioning it, but most areas want to worry about their own. So transport wants to worry about its own without thinking about the implications of not providing transport to these new outer suburbs that are so far out that if you haven't got a car, you can't move. And that is such a health, its impact on health is so huge. So then they say, well, health should be supporting it, but it's a whole of government approach. And that's where we lost the way a bit some years ago, I think, with the whole of government thing got lost. And it is important that each area runs its own portfolio, but they've got to come together to think about the person who is living in an area, about their whole needs through transport, employment, schooling and shopping and everything. So, I think, having wrapped it on a bit, I do think there has been a bit more of a movement in the last year or so because of the government we've now got federally, and a number of the state governments are trying to do so. But I think it's still got a long way to go, and people like you have got a lot more talking to do to get it out there.
Thanks, Angela. Good question. John, I was just wondering, maybe you could share with everyone, you developed the atlases with your team, and what happens? They sit on the website. Do you engage back with the federal government around the atlases? I think, there might be some people on the call who don't actually quite know the way, that your work has an impact.
Yeah, so every year we, when we've got a contract, which is usually 3 years, we then have a work plan with the Department of Health, now Health and Aged Care, and we work through that and to update the atlases and then look at anything that they might ask us to do, any developments. And we're aware of the literature, the changing infrastructure, like moving from general practice divisions now to a smaller set of areas of primary health networks, what we should be doing for them. And we actually just on Friday received a request for more information from the Commonwealth Department that funds us about who's actually using it and the extent of use. So we've got a website that tells us there's about 30,000 users a year, but that's a bit limited in what they do and so on. But we have run a survey recently, and so we put the data up. We answer queries from people. We try and contact primary health networks who are a major focus for the Commonwealth about what they want, if there's something else we could be doing for them. And we do get from time to time information, something from the Human Rights Commission last year, and federal government departments of various kinds use the Atlas data for all sorts of things. And we've got a very long list of academic literature that Greg Lobb in our group put together of people who have been writing and using the FIDO data over the last year or so. And so it is widely used as an input into other people's work as well as into teaching.
I'm talking on mute. Thanks, John. Yeah, I was going to ask you if ever you have any bites from people internationally as well. So you mentioned the Human Rights Commission. That's fairly impressive. Are there any others?
Well, I probably should have said it's the Australian one, but it's interesting that the second biggest user of the data after Australians is people from America, from the States. And I think there's a couple of universities on the West Coast that have been using our data since the very first Atlas, when they wrote to say, could they use our data? And we sent them floppy disks of the data. And I think they've kept up with that. And so, there are people, Claire's just reminded, we actually had somebody come and work with us as a student from Germany for a period of time, and then went back and was working in World Health in the same area. So we've had our contact there. We've also, we're invited to a couple of World Health meetings internationally and in the Pacific. So people are aware of the work because the Atlas is a little bit unique. A lot of this determinants data and the dividing it up in the way we do is so, but putting it together in the maps and then the way it is rather different. Yeah.
I was going to ask you, is there anything like this in the world that you know of? Like, are there comparable units that you know of?
So putting data into spreadsheets is very popular, but ours bringing the determinants up front against the health outcomes is one of the biggest compilations, and it's somewhat in New Zealand. There was some attempts, but I don't know whether they've continued. way back, maybe 10 years or more ago, were good efforts at it, using the same software that we do for mapping. But I think that the social atlas health atlas is one of the major ones in terms of the size of the database and the reach that it has.
It's a wonderful asset here at Torrens University, very much so. I can see Paul's head nodding as well. Yeah. So you might have some people approach you.
Good.
Yeah. Thanks very much, John. If we have no other questions, I'm sure things are buzzing around in some of the researchers' heads, and I imagine people may come to you in the next couple of weeks. I really enjoyed your presentation. Always good to see the work that you and your team are doing, and congratulations on such longevity as well. Floppy disks, okay. Probably not a lot of people on this call that know what floppy disks are, but anyway. Thank you very much on behalf of everyone, and congratulations on your work, and keep up the great work. All right.
Thanks very much, Kerry.
Thanks everyone, and have a good afternoon.
Bye.
Bye-bye.